Thanks for joining us for tonight's webinar, Breaking It Down, Common Orthopedic Injuries in Sports. I'm Mac Ingram, Director of Engagement, Alumni, and Students in the Office of Alumni Affairs. Since we're virtual, and this is my first time hosting, please excuse any technical issues that may pop up. If you have any problems with your video or audio, click the Reconnect button on your screen to get back to the webinar right away. A quick note, this webinar is being recorded. We will have a replay available on our website early next week. Also, if you have a question, drop it in the chat. We'll have time for a Q&A before we go. Tonight, we are continuing a special 5-part series, Push to Play, that takes a look at topics important for families of youth athletes. We're excited to welcome 2 guests tonight. Dr. Stephen Brown is a sports medicine physician and assistant professor of sports and exercise in the UAB Department of Family and Community Medicine. He earned his Doctor of Medicine from UAB in 2014. Dr. McKeag is an assistant professor and program director of the Sports and Exercise Medicine Fellowship Program through the UAB Department of Family and Community Medicine. He earned his Doctor of Medicine from Michigan State University in 2015. At this time, I'd like to turn things over to Dr. Brown and Dr. McKeag. Thank you guys for joining us.
Hey, thanks for having us.
Yeah, thanks, Matt. Appreciate the Office of Alumni allowing us to meet with you all tonight and talk about some common orthopedic issues that we see in our pediatric population. I'd like to get started tonight. I'll speak briefly on bony injuries, mainly around fractures that we see commonly in our youth athletes. And then Dr. McKeag will follow with a closer look at soft tissue injuries, so those that involve the ligaments and the muscles. So without further ado, to be polite with everyone's time tonight, we'll just go ahead and dive right in, looking at the common fractures and some information that we think would be of use to parents, coaches, and those who are involved with youth sports. So a common question that I get seemingly every day in my clinic at UAB and also at Children's of Alabama, where our sports and exercise specialists provide care, is what's the difference between a broken bone and a fracture? You know, oftentimes I'll go into a room and we'll be speaking to the patients about an injury, and their parents or the patient themselves will be, well, is it broken or is it fractured? Which is a great question, but actually they mean the same thing. So there's no difference between a broken bone and a fracture. Those are 2 terms that we use interchangeably. Some providers may use them to mean different things, whether it be growth plate injuries or trying to describe the difference between a displaced, which means the 2 bones are not lined up any longer, versus a non-displaced fracture. But all in all, a fractured bone and a broken bone are the exact same things, and we'll treat them the same. Another common question that I hear is, well, how do fractures happen? What do we need to look out for? When do we need to suspect fractures in our children? Fractures in pediatrics commonly occur just after falls. It can be a fall from standing. It can be a fall from height. I was most recently at the beach with my family on vacation, and my 2-year-old or 3-year-old decided to fall off a bar stool, right? And so immediately started limping. So then we start looking, oh, do we think that we have a broken bone? Other ways that they occur are during sports, right? There's lots of direct impact to the bones, whether that be in football or soccer, ultimate frisbee, baseball. There's lots of different collisions that occur that can lead to fractures or broken bones. Another common mechanism by which we see fracture in clinic: skateboards, bicycle accidents, and unfortunately car accidents as well. And then one that is becoming more frequent in my clinic is injuries that occur at trampoline parks. I joke with parents all the time that I believe trampoline parks were created by orthopedists to drum up business, and I'm looking at investing myself because they are great for business. Now, that's not to speak ill of trampoline parks. My kids love going to urban air, and I enjoy it as well, but it is one where we do see a pretty hefty amount of injuries that come out of those situations. Commonly, when I'm talking to whether it be parents of the T-ball team that I coach, or back when I used to coach high school and middle school basketball, is what do we need to look out for fracture? Kids come up limping, or if they're like my kids, they cry frequently, and trying to figure out what's wrong, right? So if you're a coach, if you're a parent, and your child comes up to you, what are some signs or symptoms that they might present with that should clue you in that, hey, this may be more than just a little boo-boo, right? So that could be pain or swelling in the injured area. Obviously, we would expect pain where they point and show would be directly over a bony area, although not always. There are many situations where a broken bone in one area of the arm or leg will lead to pain in other areas. Obviously, if you see a big deformity, I think we've all watched sports before, and those who have no medical knowledge whatsoever see a gruesome injury and say, yep, that's broken, right? So if you see an obvious deformity, or if the arm or leg looks like it didn't look like that before, that's probably a good indication that it could be a fracture. If children exhibit difficulty using or moving the affected area, that's usually a pretty good indicator in children, especially those that can't express to you that they're injured, especially when we think about toddlers or young children who can't verbalize that they're hurting. If you notice them limping, refusing to use their arm, that can be a good indication. And then warmth, bruising, or redness to the injured area can also kind of clue you in that, hey, there may be more at play here than just a bruise. Biggest piece of advice, if you have any concern whatsoever, we do recommend that you seek medical care sooner rather than later if there are signs or symptoms of a fracture. Obviously, if you see a break in the skin and a bone poking out, that is a medical emergency. We recommend that you proceed to the local emergency room or orthopedic urgent care in order to get that treated. Obviously, if you suspect a fracture, removing the child from any areas of danger, whether that be out on the playing surface, whether that be in the street if they have a bike or skateboard accident, removing them from any potential dangers is important first and foremost. Second, we want to support the injured area. So whether that be with a makeshift splint or a sling, or simply the parent or coach holding the affected limb so as to minimize movement at the potential fracture site. If there is an open wound where you see a break in the skin, it is okay to wash the area with soap and water. Obviously, we don't want to apply the old adage of rub some dirt on it if you see a broken bone, right? That can predispose us to infection, which can cause significant complications. So water and soap, but please avoid dirt or turf pellets if possible. And then again, if you suspect that there's a fracture present, we do recommend that you seek urgent medical treatment or evaluation. It doesn't necessarily necessitate an ambulance ride, but we'll also kind of leave that to the discretion of the parents, because I always tell my parents, you know your child best and know when they're just not acting themselves. Another common question that I get are, what are the most common fractures that we see? In children, upper extremity, so meaning the arms or the upper body fractures, are significantly more common than the lower extremities. Some of those upper extremity or arm fractures that we see include broken wrist, broken elbows. We'll see clavicle or collarbone fractures fairly commonly. In the lower extremity, they tend to be more foot and ankle fractures. We do see thigh bone and hip fractures. We can see shin bone fractures, but those tend to be higher velocity, more tied with falls from height or car accidents. Other things that we think about with broken bones, or are broken bones that we see in adults the same that we see in kids? And the answer is no. If you speak to any pediatrician or any medical provider who provides care for both children and adults, such as a family medicine physician, which is what myself and Dr. McKeag are trained in addition to sports medicine. Children are not little adults. They are very much distinct from their adult counterparts, and the same is true in orthopedics. So we see different morphology or types of fractures. We see different locations of fractures in children. We know that children's bones are different than adult bones. So children's bones are growing. There's not many people going through adult growth spurts. So those growth plates that are present in kids can be of detriment and benefit for the children. Those growth plates are more likely to be injured compared to other areas of the bone, but there are some characteristics about children's bones that lead to faster recovery. So we know that the periosteum, or the outer layer of cartilage and connective tissue over the bone, is thicker in children than in adults. So that is why kids' bones tend to heal faster than adult bones. So when people are like, well, my kid was only in a cast for 3 weeks, why do I need to be in a cast for 8 as an adult? Well, it's because your bone doesn't have that extra blood flow. With growth plate injuries in kids, the common thing that we hear is, oh my gosh, is this going to cause their leg to be shorter than the others? Growth arrest or cessation or stopping of the growth of a bone is a concern when we have growth plate injuries, but we will say that it is much more rare than you would think with growth plate injuries. It is something that we'll be aware of and will require serial follow-up over time, but it is rare that we see true growth arrest or stop of growth or growth cessation from growth plate fractures in children. We also know that children's bones are more flexible, right? So you'll see some kids take some gnarly hits and some gnarly falls, and you'll think, ooh, had to break something, and the kids will be completely fine. So they tend to be a little more plastic than our adult counterparts. But because of those flexible bones, we do see some unique fracture patterns in kids that we don't get in adults. So it's one where you really want to seek out orthopedists or sports medicine specialists like myself and Dr. McKeag, who have specific training in pediatric fractures, because it is a little different. It's not just treating the same as adult fractures. So our sports and exercise medicine specialists at UAB have clinics both at UAB, but also Children's of Alabama, and we're all specifically trained in pediatric fractures and pediatric orthopedics. In fact, at UAB, we have the only 2 pediatric trained sports medicine specialists in the entire state of Alabama. So those that trained in pediatrics. So we really are blessed with the resources that we have for the children of Alabama. And then finally, I'll wrap up my time with just a little plug on how we diagnose and treat fractures. So once you bring them into the clinic, your child will get radiographs or plain x-rays because it will help us to identify, 1, is there truly a fracture? 2, what type of fracture? So are the bones still lined up? Are the bones offset or misaligned? And it will help to guide treatment. Is it something that we can treat with simply a cast or a walking boot, which the overwhelming majority of pediatric fractures are treated non-operatively or without surgery? So after those radiographs, we'll discuss what the findings are, and oftentimes it does require a cast or a walking boot. And then it's a period of immobilization. Most pediatric fractures, it's anywhere from 2 to 6 weeks. Sometimes if the bones are not lined up, we will need to give some medicine to relax your child and then line those bones back up so that they can grow back. The nice thing is the way that children's bones heal, that they can overcome a significant amount of deformity and grow back and remodel over the time childhood years and create a completely normal or straight bone. Children really are amazing in their healing capacity. And then finally, what are some steps that parents and coaches can take to prevent fractures? It really is all about excellent training, right? So making sure that we're teaching kids how to properly perform sporting activities, making sure that they're wearing all appropriate protective equipment. So that includes helmet to protect our brains, shoulder pads, knee pads, elbow pads, whether that be for sport or for skateboarding or biking, making sure that we're maintaining good nutrition, because we do know that decreased nutritional status can increase children's risk for fractures. And then making sure that we're doing our best to ensure that children know the rules and the appropriate ways to perform sporting activities. So in Alabama, football is king, right? And we see football, tackle football beginning in the first grade in some places. So it's one of those where making sure that you have good qualified coaches who have been certified by Safe Sport, which we're a big proponent of here, and Coach Safely here in the state of Alabama, but also making sure that you're overseeing those coaches and make sure that they're practicing good tackling technique and really teaching the fundamentals of the game, so children can participate safely. And with that, I'll turn it over to Dr. McKeag, who touched a little bit on soft tissue injuries.
Thanks, Stephen. So first off, that was great. I couldn't agree more on everything that you said there. The one nice thing that Dr. Brown did for me is he took the more difficult of the two sides of this conversation. From the standpoint of soft tissue injuries, when we're talking about the pediatric population, kids are incredibly resilient. Their tissues are incredibly tough and flexible, and so oftentimes what happens is when a child gets into a compromised position, that would typically result for an adult in a torn piece of tissue or any of these soft tissue injuries that we typically see. A child actually is more likely to end up with a fracture, an actual broken bone, because their tissues are actually stronger than those bones. So we actually have what's called avulsion fractures that occur where that tissue creates such a force that it actually snaps that bone instead of the tissue itself. That being said, we still get plenty of kids into our office that have these soft tissue injuries. So from most folks that we're talking to, you're going to be when you think of soft tissue, you're going to think of things like bumps and bruises, small cuts, abrasions, things like that. A lot of those can be treated at home, and you probably don't need me to waste your time talking about it. Or if you do, I would encourage you to discuss that with either one of us in the office or with your primary care physicians. That being said, we also get things like ankle sprains, wrist sprains, muscle strains, or just kind of generalized muscle soreness. All of those come into our office, and they do have a certain level of severity that will grab our attention when needs be. So when we talk, though, specifically about what soft tissues are getting involved in a lot of these injuries, I think it's important to break down what kind of soft tissues are involved in general. So we're talking about muscles, tendons, ligaments, cartilage. Those are really the big ones. I think most of us should know what a muscle is doing. It's contracting to give us our movement in the body. A tendon is simply the tissue that attaches muscle to bone. A ligament, on the other hand, is attaching bone to bone. And then cartilage has a handful of different functions, but cartilage is traditionally thought of as that surface on the end of the bone that is helping to keep a smooth surface for our joints to move in and bend in. But there are other areas in the body, like in the knee and the shoulder, that it's either being used to help increase stability or to provide an additional shock absorber and cushion. And we'll kind of talk about that a little bit later. The main thing here, though, is that each one of these tissues differ greatly in function. Because of that, they differ greatly in tensile strength. And then probably most importantly, when it comes to the recovery of your child, they differ greatly in blood flow. And so that's usually the most frustrating part for a lot of patients that we see, in that as Dr. Brennan brought up with like fractures, bone is an incredibly large source of blood flow, and so they tend to heal incredibly quickly, and assuming that they're put in the right environment. But on the flip side, things like ligaments and cartilage really don't have that much as much blood flow. Cartilage especially. And so you'll notice that depending on what you have injured, the length of time with which you're shut down, so to speak, is going to vary greatly. So now let's talk about some of these specific areas that folks have injuries. So the big one, the catastrophic ones that we all hear about when we watch TV and watch our favorite football team, or you hear about your the star athlete at high school, are going to be things like meniscus tears of the knee and ACL tears of the knee as well. So we generally don't see a lot of these types of injuries in the younger kids. So under the age of 10 or 12, they tend to have other injuries go on in their joints rather than an actual tear of these structures. Now, don't take that too literally, because there's always folks that are going to have some third cousin that tore their ACL at age 8 or something like that. But generally speaking, we see that in the adolescent years, high school age, and definitely in college. And so an ACL tear is going to be a surgical fix for all of our athletes. And generally, just about everyone needs to have surgery to reconstruct that ligament. The ACL itself is one of the 4 main ligaments of the knee, and when you tear it, it drastically reduces your ability to keep that knee stable. And so you'll hear of folks who have a chronic ACL tear and never got it fixed, but that's few and far between, and so that's just something to keep in mind. The other thing with our ACL tears is the female population is at a much greater risk of these injuries than the male population. Depending on where you're getting your research, it can be anywhere from twice as high to 8 times as high. And so that is a major risk for our female athletes. And so, and then it also varies depending on your sport. So sports like soccer is at a greater risk for an ACL tear than something like track and field. Football is another one, but these injuries tend to be a change of direction, non-contact, which may surprise many of you, but non-contact, change of direction, or pivoting injury, where someone is essentially planting that foot, and then unfortunately that knee gives way. A meniscus tear, on the other hand, involves the cartilage. These are used to be almost entirely treated surgically. Newer data is showing that they're not always a surgical indication, and so I do recommend folks kind of going into these types of injuries with an open mind. But meniscus tear is essentially a thick piece of cartilage inside the knee that works as a shock absorber. These injuries tend to be, again, athletes that are pivoting or twisting, and they oftentimes are injured at the same time as the ACL or some of the other ligaments there. But those are really the big ones that we see in our youth. Those are the ones that people are most afraid of, because they more often than not do push these athletes and these young athletes to the operating room, which is obviously something that we actively try to avoid. You'll also have joint dislocations and subluxations. So the difference between a dislocation and a subluxation if you're a nerd like Dr. Brown and I, is not something that most parents need to know or care about. But from our perspective, a dislocation is when the joint fully comes out of its placement. These typically stay that way. They need someone to actually put it back, or maybe the athlete puts it back, him or herself, versus a subluxation where the athlete definitely feels the injury itself, but it's more of a sliding partially out or starting to come out. It never fully comes out, so it slides back in. And these folks definitely have an eye-opening experience, and then a lot of swelling afterwards. But the good news is that no one has to come in and actually reduce that joint back into its place. These types of injuries are also at greater risk based on what sport these athletes are playing. So shoulders. First off, the shoulder is the most mobile joint in the entire body. So there are some kids out there that you can, catch a crosswind in the wrong direction and they'll dislocate. But the main thing is that if they are put into a compromised position, like the arm and an extended and what we call abducted position with some external rotation, they're at a higher risk. And so that's why when Dr. Brown had brought up tackling mechanics, that's so important. We're trying to reduce obviously our concussion rate, but also things like a shoulder dislocation or subluxation by not doing arm tackles and actually tackling with the body. On the other hand, wrestlers and gymnasts have a higher risk for things like elbow dislocations. And so those are just things that usually require medical personnel to actually put back in. But we don't typically see an elbow dislocation, for example, on the basketball court or really even on the football field. Dr. Brown might disagree with me on that one, but yeah, definitely our wrestlers and gymnasts. Then we also we kind of get back to the ones that we're all used to, right? Like ankle sprains, wrist sprains. Those are things that are definitely things that these kids are getting regardless of age. The main thing that, and I'll probably want Dr. Brown to add his tidbit here, but from my standpoint, with an ankle sprain or a wrist sprain, depending on the age, we're obviously going to get an X-ray on these kids if they're guarding this joint to a significant level. But for the most part, these are injuries that will heal on their own. Especially in the really young crowd, if we don't see an actual fracture associated with it, then generally speaking, you can feel pretty comfortable that you didn't disrupt any of the soft tissue at the same time. And then from my standpoint, I start to focus more on our red flags, like, is this child limping consistently? Do we have profuse or persistent swelling? Do they have pain over some of the bony prominences? And then other much more high-risk stuff, like, do they have any numbness or weakness in the extremity? Dr. Brown, do you have anything that you wanted to add on that one?
No, it's one of those where it can be quite difficult, especially with the ankle and the wrist specifically, because of the proximity of growth plates to those soft tissue injuries, to really delineate what's a sprain or a stretch of the ligament versus what's a strain, which is a stretch of the muscle, versus what is a growth plate injury or a potential broken bone. And so typically, if there's no outward deformity, when I used to be on an injured child call back at my previous jobs, it'd be one, well, you can provide some ibuprofen, you can provide some Tylenol at the appropriate weight-based dose, you can protect the area, which most of the time the children will do a good job of not letting you touch it and not wanting to use it, and see if they get better, right? If you still notice after a couple hours or even into the next morning, if it occurs in the evening, there's still not wanting to touch it, not wanting to move it, they don't want you to touch it or move it, then that's oftentimes when we say, hey, it would be a good idea for you to come in and see us to help delineate, is it a bony injury, which is much more common in early childhood than those bony injuries, and the soft tissue as our children continue to mature faster and faster nowadays as we see puberty move up to younger and younger ages. Those soft tissues then come into play. So it's one of those where definitely in our high school athletes and collegiate athletes, we definitely see more soft tissue as opposed to bony injury, and that flip-flops back in as we get younger.
Awesome. Yeah. The just to wrap up with some of the other kind of more generalized things. I know, I believe Dr. Spellman actually covered on a previous podcast with the apophysitis and overuse injuries. So that's another one that we see a lot. Obviously, in order to actually have apophysitis, you have to have open growth plates. So that's strictly a pediatric or an adolescent issue. And but those are, again, going to be much more related to kind of an overuse, repetitive type of injury thing. You can have more acute apophysitis, but it's less common. The most common thing that we see in our young age group that is just always walking through the door is going to be patellofemoral pain. So that is generalized kind of, we call it anterior knee pain, or knee pain that is kind of on the front side by the kneecap. And that is something that, again, is seen more often in women than men, or I should say females rather than males, but can be really, really uncomfortable for these folks. Generally speaking, we can help these kids with just some biomechanical kind of rehab, and then some anti-inflammatories, and maybe even some change in their footwear. And then lastly, I did want to discuss just generalized muscle soreness. I think that it's something that's, especially in our coaches, it's easily kind of pushed aside just because a lot of times they're exercising these kids maybe after a long break, and they're out of shape, and in the vast majority of the cases, that is 100% correct. That being said, a little bit of an understanding of the difference between what I would consider benign muscle soreness versus much more serious muscle soreness. So muscle soreness should be something that might be acutely present when they're exercising, but it should get better after they rest and they rehydrate. Especially if we're talking about a deconditioned individual, or maybe exercising a new muscle group, or just doing a new activity. They may have a peak in muscle soreness that they maybe wake up to 24 to 72 hours after doing this new activity. But what they shouldn't have is they shouldn't have debilitating soreness that is, especially in our large muscle groups, that is in our kind of our flanks, our back, our hips, our buttock, that is getting worse and worse and worse, to the point where they are maybe doing a 3-point stance where they're on their knee and just trying to catch their breath, and is as truly debilitating in getting them back to up to speed. So when they do show that type of sign, we're looking at one of two things. One is going to be something called rhabdomyolysis, which is a very concerning, I would put it in the category of medical emergency. These kids will have reddish tinged urine and an exquisite, unrelenting muscle pain. If gone untreated and allowed to get to persist and get worse, it can lead to kidney failure. And then on the flip side, if the child in question is known to be a sickle cell carrier, so it doesn't have to be sickle cell disease, but sickle cell trait, Then the other side of it is that we're concerned about kind of a sickle cell crisis at this time, which also predisposes to rhabdomyolysis and has a lot of the same treatment and all that, but and a lot of the early on symptoms, but those kids are going to be more prone to that type of injury. So that's just some of the things that we're really looking for. And then, like I already said, the red flags, regardless of what type of injury we're talking about, is a child who's limping, and that's not I twisted it and I'm walking off the field and I'm fine by the time dinner arrives, but a persistent, the day after, I can't walk without a limp. The feeling of instability or the feeling of like a mechanical locking, especially in the knee, profuse or even persistent swelling of a joint is another thing that we're worried about. And then, bony pain, but that's obviously something we're a little bit more worried about with a fracture. Same as what Dr. Brown brought up with like bony contours or prominences that maybe shouldn't be there. And then the big ones is numbness in the extremity or an extremity that's cool to the touch. Those are the big ones that need to be seen now. And I think that's about all that I had planned.
Fantastic. Hey, that's that was some fantastic information that both of you provided. We have had some questions come in, so be sure if you have any other questions to drop them in the chat. We'll get to them right now. So first up, I have, what are some exercises female athletes can do to prevent ACL knee injuries?
That's a fantastic question. And so the good news for everyone is that the exercises are the same for men and women, but there are specific kind of what we call them kind of agility exercises, but really exercises that that work out the major muscle groups for stability at the hips and the knee. So the big muscle groups that you want to target are the hip abductors. So that would be the like gluteus medius, if you want to look that up. But that's essentially what allows you to, if you're standing straight up, allows you to bring your ankle away from the body and kind of into a V shape away from the body. I would say that, because everyone, when you say that, they think of the machine at the gym that they sit down and do kind of the clamshell. That is actually working out more of the muscle called the tensor fasciae lata than it is the gluteus medius. So I would specifically work on with those athletes what I call a lateral leg raise, where they're laying on their side, their legs are straight out in front of them, and they're raising that ankle up off the ground. So that's a big one. Core strength is another. Which is very big, and then quadricep and hamstring strength has also been shown to predispose individuals to ACL tears across both sexes.
And I'll kind of hop in here and add to this. The good thing is we know that strengthening is a big part, but neuromuscular adaptation plays a huge role in ACL risk reduction. And so there had been there are a few different ACL prevention programs that you can utilize that are available free on the internet. For competitive soccer players, there's the FIFA 11 program that's widely available in PDF form that has been shown to reduce, when appropriately used, risk of ACL in competitive soccer players. So that's FIFA 11, FIFA 11. You can Google that, ACL prevention. There's also the Santa Monica PEP, or it's the Santa Monica ACL Injury Prevention Project, or the PEP program. It was one of only two that was found to be statistically significant in reduction of ACL injuries in female adolescent athletes. The other one is Sports Metrics, that's sponsored by Cincinnati Children's Hospital. That is one that is, at last check for me, don't quote me on this, it was not free access. You could be trained in that. But the Santa Monica ACL Injury Prevention Project, or the PEP program, is available in PDF format on Google. So if you're really looking to institute that yourself, you can access those. But we also have a great exercise an injury prevention program at UAB. We work closely with physical therapists and personal trainers in the community. So if it's one where you have concern, or maybe your daughter or son has suffered an ACL injury before, or you have concern that they may be more than happy to see you guys and help to plug you into community resources. We are blessed in the greater Birmingham area with lots of great resources available for injury prevention.
Absolutely. That is awesome. That's great stuff. Okay, next question. Do you see Achilles tendonitis very much in the teen and preteen athlete? And if so, how much return to sport time are they facing versus us adults?
Yeah, so that's also a really good one. So with Achilles tendonitis, so it depends on the age. So our younger kids, the short answer is no. We don't typically see that too often. There is a condition called, depending on how you pronounce it, either Sever's or Sever's disease, which is basically a fancy term for a inflammation of the growth plate in the back of the heel. And so that can mimic or basically cause Achilles tendonitis-like symptoms. Once that growth plate is gone, then yeah, you definitely can. For the kids that have that kind of issue, we typically target a handful of things. So one would be obviously the flexibility of that Achilles tendon is commonly tight in those individuals. Hamstring tightness is another thing that can predispose folks to that. And then looking at their foot shape as a whole. So folks who are who have a higher arch can definitely have some issues there. Proper footwear is number one. So if they're in bad footwear for the shape of their foot as a whole, then it can really set things off, and we could be kind of on an uphill battle at that point. And then what we typically do for those folks coming in is we give them like a little bit of a heel lift in order to try to offload that Achilles tendon as much as we can. When it comes to recovery, generally speaking, Achilles tendonitis is a nagging issue across all levels. And if a child is kind of in their peak growth spurt age, unfortunately, that can be something where that's going to keep them from really coming all the way through it in a quick manner, because their bones are growing, it's stretching out that Achilles tendon because everything's lengthening. And so that can slow things down. But generally speaking, the younger you are, and the more fit you are, the faster you're going to recover from that kind of condition. Uh-oh, did we lose him?
Yeah, possibly.
We might have. I can see the next question. Want me to ask you?
Yeah, that'd be fine.
All right. So, Dr. Brown, not all fractures show up initially in kids. Do you have any recommendations if you have a suspicion for a fracture, but the initial x-rays are essentially inconclusive?
Yeah, so at the risk of sounding redundant, another great question, right? So this is actually something that we spend a lot of time teaching our fellows and residents and learners, that not all fractures initially are apparent on x-rays, especially when we're dealing with growth plate injuries in children. So the thing that we teach is, if they hurt when you press on the bone and you suspect a fracture, you treat it whether you see it or not. And so that's commonly with a brief period of immobilization, and then typically follow up with repeat x-rays in a matter of weeks. So we commonly see this with those distal bone fractures, so meaning the ends of bones, the wrist, the ankles. So yes, it is possible that when you go to the urgent care with that first and they say there's no fracture, then your child continues to hurt and they follow up with us in the clinic and we say, well, yes, there's a fracture there, that it might not have been easily seen on x-ray. So it tends to be more of a clinical suspicion if we have a mechanism that fits a fracture and then also pain directly over the bone, we will commonly treat as a fracture with immobilization. So that includes casting, splinting, protecting the area.
Awesome.
Hey, I am sorry. We have a storm where I am, so mechanical issue. Technical issues actually did happen. My internet went out, so I panicked to make sure I reset everything. So appreciate everyone and y'all continuing on while I was going. I will. I'm going to move on to the next question right here because I had to look it back up. Let's see here. Do kids, adolescents who dislocate or sublux their shoulders need surgery? What are some preventative measures, exercises to help them not have those issues?
I was not anticipating you all bringing up some of the more controversial topics in sports medicine. So I'm going to preface all of this with, this is my opinion based on the data that I have seen, and obviously with my own biases. So if you had a phenomenal surgeon like Dr. Amit Mamaya, who is our head sports medicine surgeon here, he may agree or he may not. So, but that being said, so adolescents who are dislocating a shoulder specifically, or even for that matter, dislocating their patella or their kneecap. The question has always been, do we repair it and tighten them down right out of the gate, or no, regardless of if we see any structural damage on imaging? And so if that image is clean and they just dislocated and it's a one-time deal, my go-to is absolutely not, is we get them set up in some good evidence-based physical therapy and make sure that they're compliant, discuss maybe with, either them, their parents, whatever, however we want to do it, of all right, how did we get ourselves in this situation in the first place? Are we arm tackling, whatever, but we essentially get them rehabbed and strong. And then if they continue to dislocate or sublux despite proper management and physical therapy, and compliance is key because kids say that they do all sorts of stuff and don't, then at that time there are proper surgeries to have that done. And I will say that that's based on both my medical expertise, but also my personal experience. So we're talking 2 shoulder surgeries here and none here, and both have been dislocated. So we're I've had great success with both of them. It just depends on how mature you are at the time of injury.
Yeah, and so I agree. It's one of those where a lot of it's going to be tailored to your specific injury or the child's specific injury. Age at first dislocation plays into it. The mechanism, was it traumatic, or were they just going out for a swim or walking the dog and the shoulder popped out? Did they roll over in bed and their shoulder popped out? Obviously, is there surrounding or other tissue injury? Most that I see in clinic are clean. They're wrestling or they're in PE or they fall and their shoulder pops out and all their other soft tissues are normal. And often that does require additional imaging in the form of an MRI, where we look at those soft tissue structures. But like Dr. McKeag referenced, sports medicine tends to be a pendulum specialty, right? And it swings back and forth between early to surgery, late to surgery. Do we operate? Do we not? The truth of the matter is it's all dependent. There's no catch-all answer in sports medicine where we treat every single injury exactly the same. But it is one of those where we do recommend that if you do suffer or your child suffers a subluxation or a dislocation, that you seek a sports medicine specialist who is up to date in those most recent practices, because just like the Apple iPhone updates seemingly every year now, so does sports medicine. and you're kind of getting an idea as to what our national conferences are like, where you've got different people on different sides of the room supporting different types of treatments, and us trying to come up with what's the consensus best answer.
I can only imagine with the way technology changes. I can only imagine the things that change in y'all's world. Okay, so next question up, I have not all fractures show up initially in kids.
We already got that one while you were trying.
Did you when I was out on? Okay, good.
Yeah.
Did y'all talk about the footwear for patellar?
No, we only got to that one.
I'm glad you stopped me there. Okay, so what is the best footwear for patellar femoral pain?
So I'll take this one as well. But it's going to change based on who we're talking about. So everyone has their own foot shape. They all have their own foot structure. Same thing goes with kind of the bend and angle of their knees. So I can't just catch all say, oh, it's going to be this or that. The main thing is going to be focus on a shoe that is comfortable. Not just comfortable when you put it on once, but comfortable when you exercise in it. So that's going to be your greatest benefit right then and there. But generally speaking, even if you have a relatively flat foot, I tend to be a little bit on the aggressive side when I recommend getting some some footwear that has some added arch support. Because many of those folks, if they do have a flat foot, they have a tendency to what we call pronate, and that can lead to patellofemoral pain. We have some great companies around town that will actually take a look at your foot and sell you a pair of shoes that is specifically for your foot shape. It is not a gimmick. I strongly recommend, if you've never had that, then do it. Because the only thing that can really derail an athlete is, across all spectrums, is a bad set of shoes. The last thing is, if it becomes a big issue, then custom orthotics, maybe not so much in our pediatric population, because they are their feet are growing so fast that it's not worth the money. But once you have someone in their late teens and 20s, and then on up, custom orthotics can make a big difference. And so there's one company around town that has really done a great job of giving the people of Alabama some high quality custom orthotics, and I can't recommend them enough. I just don't know if I'm allowed to. But we will also at UAB in the next 6 months, we'll actually be doing our own sports custom orthotics, basically at the January of 2024. So we'll have that as an option. But again, I for our kids, it's not worth the money, but definitely get them in something that is comfortable. So not so flashy. I know they all want their Jordans and whatever is the new hot shoe at the time, but those are not always appropriate for each individual.
Yeah, and I will defer to Dr. McKeag on that, because he is actually our footwear specialist. Trained with one of the world's leaders, really, in foot biomechanics and things like that. And so a plug for him and his clinic. He will actually be offering custom orthotics in the near future at UAB Sports and Exercise Medicine. And we really hope to increase our running medicine component of our sports and exercise medicine with some staff that we're adding from UCLA in the coming months. So it's one of those where if you have questions about footwear, interested in orthotics, UAB is definitely one of the leaders in town when it comes to running medicine.
That's awesome. That is really cool. That is another one of those amazing things our university is doing. Okay, so next up, would you encourage cryotherapy and compression therapy for recovery from sore muscles and sprained ankles?
So this is another commonly debated. So I think everybody here is somewhat familiar with the traditional Rice method. You know, when I was growing up, my dad was a high school basketball coach, and so we injured an ankle. It was foot goes immediately in the ice bucket, right? We want to cryo. Then we would do the hot to cold transition, right, and do the ankle sprain and the compression. And so for decades, really, the RICE or the rest ice compression elevation was kind of the gold standard in treatment of soft tissue injuries. Well, what we're finding now is that really all they need is some peace and love, right? So there was a new mnemonic that's been created. There's actually a good free paper available in the British Journal of Sports Medicine that really explains what that peace and love means. And just briefly, it is a mnemonic, which in medicine we tend to love, not me personally, because I can never remember what they mean. But the peace and love stands for protection. So we do want to protect the injured body part against excess movement. You do want to elevate it to help control swelling. The A is we actually encourage now for you to avoid anti-inflammatories. So ibuprofen and Aleve were traditionally the go-tos, and now we're recommending things like acetaminophen and non-anti-inflammatories because we know that inflammation is the mechanism by which tissues heal. So it's kind of this give and take of pain relief and anti-inflammatory. Are we inhibiting healing or are we promoting? And now that pendulum that I mentioned is swinging toward avoiding anti-inflammatories. Compression still does play a role. Education, your body knows best, so you need to avoid any passive treatments or investigations that are going to inhibit that. We do want to load those areas, so you let pain be your guide when it comes to soft tissues. Vascularization is important, so we want things that are going to promote blood flow to the area. So that's actually where ice and cool cryotherapy has actually now kind of fallen out of favor for acute soft tissue injury. Now, we could have another talk about physical activity performance and the use of cryotherapy in acute just sports performance. And we could have a whole another 2-hour talk about that, which we may in the future. But it is one where now the recommendation is kind of avoiding anti-inflammatories, avoiding ice to the area, do perform elevation, do perform compression, and we actually want you to exercise or perform active therapeutic exercises to that injured area. So just remember, soft tissue injuries need peace and love.
I'm actually going to show the audience just how controversial some of these things can be, because I agreed with most of what Dr. Brown just said, but I actually am still a pretty big advocate of ice, just in moderation. I feel like, especially in the pediatric population, kids don't really like things to get cold, but diminishing the swelling can also provide a significant amount of pain relief just in and of itself. So I usually recommend 20 minutes on, 20 minutes off, 20 minutes back on, rather than, full cold immersion for, half an hour to an hour and then kind of letting that go. So there's definitely an art to it. There's definitely folks that disagree. Dr. Brown and I will probably fight about it later, and he'll likely win. But
by the way, no, I'm just
yeah. But I think that unless you overdo it, you can still kind of live within that gray area.
Well, I know that one hits a little close to home. I've spent a lot of days in the training room spelling the ABCs with my sprained ankles, and then that water and that ice was cold. Still remember it. All right, our next question: based on your experience with ACLR, are you seeing lower re-tear rates for quad tendon grafts as opposed to patellar, hamstring, or autologous repair? I apologize, I don't know how to say that last word.
Yeah, so this is, again, we are really hitting at the most controversial topics. If you go to the American Academy of Orthopedic Sports Medicine, so our sports medicine surgeons at UAB are Dr. Amit Mamaya, Dr. Aaron Cass, Dr. Thomas Evely, and Dr. Eugene Brabston. They have these conversations very frequently, right? So the kind of catch-all non-answer answer, which I tend to be pretty good at, is it depends on the age of the child, right? Unfortunately, in sports, we are seeing more and more young adolescent ACL injuries. And we have to consider growth plates that are still open versus growth plates are closed. This is the $1 million question in orthopedic sports medicine surgery, is what graft do we use? What approach do we use? Do we do an anatomic reconstruction? Do we do a transtibial? Where do we place those tunnels? Where do we place the anchors? And then what type of graft do we select? Do we select a graft from yourself? Do we select a graft from a cadaver? And what they're finding is that it really is dependent on your child's native knee architecture. Also, the quality of graft. There's some interesting work being done at Boston Children's of using IT band now as a new type of graft. There is the traditional patellar tendon that a lot of surgeons are still using, where they use bone from your kneecap, bone from your shin bone, and the patella tendon and the muscle that connects the two for that. We do know that that portends some risk down the road of osteoarthritis and other things. We do know that certain hamstring ones can portend a higher re-tear rate compared to maybe the quad tendon. There is some debate between those numbers, right? Sometimes the numbers that we see in studies don't tell the whole story. There is an interesting newer technique in our high-level competitive athletes that include what's called a LET procedure that actually Dr. Amit Mamaya is one of the only ones in the entire state of Alabama that is performing that type of ACL reconstruction. It's an additional surgery at the same time as the ACL, that there is really good evidence that's emerging now that adding this LET procedure to the ACL reconstruction is significantly decreasing re-tear rates, which is ultimately what we're looking for in ACL reconstruction, is how do we reconfigure the knee and make sure that it doesn't re-tear so that we can get athletes back to their previous level of function. And so it's one of those where I really encourage parents, encourage coaches, those that are talking with these children, to really do your research, right? Look at patient reviews, go and meet with multiple different surgeons and ask those questions because every answer is going to be different based on your child. And I would urge caution if you find someone who says that I do the same surgery on every single patient, regardless of their situation, right? Because it'd be one where what type of tear. Now there is even a surgery that we're offering at UAB that is not a reconstruction. We actually allow the ACL to heal itself. Some pretty interesting technology called the Bear implant, which is appropriate for a certain subset of populations, but UAB is the only place in the state of Alabama that's offering that too. So we really are, I feel like I'm an infomercial for UAB, but we really are at the cutting edge of sports medicine in the state and nationally. And so it's one of those where if you have those questions and you suffer an ACL reconstruction, come in and meet with us. Just because you meet with us doesn't mean that you have to stick with us for surgery or your treatment. But I will tell you, more patients than not show up in our offices and are glad that they do.
I can imagine.
How's that for a non-answer?
Hey, that's perfect. Dr. McKeag, do you have anything to add to that? You good?
No, I think he covered everything perfectly.
Nailed it.
Yeah, it's a
All right.
pretty wishy-washy scenario, and just like you said, everyone's a little bit different, and every injury is a little bit different. So even if you have two kids, two twins that unfortunately have the same injury, and they may have different tissue that's involved, despite the the same ACL is torn, but someone might have posterior lateral corner injury and the other may just have MCL and a meniscus or something. But either way, I would trust the surgeons on their recommendation, but also this is your kid you're talking about, right? So never feel like you're putting anyone out by getting a second opinion on something. Some injuries do need answer quickly, but so don't him and haw and wait 2 months to get that second opinion, but don't medicine is still a service, right? So you're not putting anyone out. We're here to help you out. This is an unfortunate time for you and your young athlete. Let us help you out and give you the best recommendation that we have. Don't feel pressured to do anything.
Absolutely. We have a couple more questions before we end the night. Next one, what muscles need to be strengthened? I think this is talking a little bit to the subluxations and the dislocations in the shoulder. What muscles do they need to work out and try to strengthen?
Yeah, so that's going to be the muscles of the rotator cuff. So that's going to be the most important thing. So there are 4 muscles there: the supraspinatus, subscap, infraspinatus, and teres minor. Dr. Brown, thank you for not saying anything when I said them out of order. But so those are going to be the most important. But then you get to the scapular stabilizers. So you get basically the rhomboids and everything that's around the shoulder blades, the trapezius muscles, the latissimus dorsi, serratus anterior. All of those are very important in stabilizing the shoulder girdle as a whole, including the pec major and minor. But the big thing here, honestly, is going to be how they're getting injured in the first place. So like I said before, the shoulder is the most mobile joint in the body, one of the most mobile joints in the animal kingdom. And because of that, it is incredibly unstable. And so it doesn't matter how much strengthening you do of every single muscle that provides even a lick of stability to that shoulder. If your child is arm tackling, it is a matter of time that they get into abduction, external rotation, and then that thing pops out. So, so it's much more important to focus on the technicalities of proper tackling or proper biomechanics of whatever sport we're playing. And then with a side of, well, let's get this shoulder strong, strengthen up that rotator cuff. And then I would actually go as far to say, make sure that their posture is nice and tight. A forward-facing shoulder, in my opinion, is an unstable and angry shoulder. So get those shoulders back, and you should have a little bit more success in the long run.
Mm-hmm. Awesome. Dr. Brown, anything there?
No, that was great. Yeah, the short answer that I typically give people is when you think about a joint that subluxes or dislocates, think about the muscles that are holding that in place and strengthen those. So, you don't have to know the names of each one, but you're like, oh, shoulder, I should do some external rotation, some internal rotation, some curls, some extensions, and just really trying to think about isolating those muscles that hold that joint in place and strengthen those.
Absolutely. Okay, last question I'm seeing. I think this is talking about back to the ice and those kind of things, and what do we do, and what's encouraged, what's not. But what about alternating ice and heat?
Yes, this is a great. So you're actually touching on something that you may not even. It's called contrast therapy. It's another one that has its pluses and its minuses. So when we talk about alternating heat and ice, we need to realize that healing is about circulation, but circulation is not just blood vessels. It's also the lymphatic system, right? And so the lymphatic system is essentially the drainage pipes of the body, right? So it is how our body gets rid of waste, including inflammatory waste. And so the idea behind contrast therapy is that heat actually stimulates lymphatic drainage from an area. So the idea behind ice is that you're calming down inflammation directly, but then you're heating up the lymphatic system so that inflammation and fluid can be drained away from the area. So that's one of the benefits of contrast therapy. When we talk about alternating heat and ice, obviously that contrast therapy will help with inflammation reduction, both through the lymphatic system and the vascular system. Also in therapy, we know that heat reduces tension in those structures. So before we get ready to warm up, that's why often if you go to physical therapy, before you get started, they're going to put a hot pack on you, right? We're going to loosen up those joints, loosen up that soft tissue, and then immediately when you're done, what do? Slap ice on you, right? So there is a role for both heat and ice. And so don't tell my dad I said this, but he was right back in the day, right? The cold tub and the hot tub, all those hours that I spent in the training room, like you mentioned. But it's one of those where we always like to remind people you should not be causing skin injury from prolonged exposure to heat and ice. I cannot tell you how many people come in with what we call dermal injuries or skin injuries from either prolonged ice or heat. But there is benefit to contrast therapy, most definitely.
Yeah, I agree. I think this kind of goes my typical, before Dr. Brown totally derailed my typical recommendations for patients with his other statements. What I tell folks after, an ankle sprain or just a common soft tissue injury is for those first 7 days or so, I recommend ice elevation compression, with some range of motion exercises just to keep everything moving. But essentially that's kind of the idea. And then after 7 to 10 days, alternate to ice and heat. There we go. And so that's as we start to ramp up whatever little exercises that we give that person for whichever injury we're talking about. That's kind of the overall kind of take-home message that I give folks that apparently is going to be fighting words later.
No, like I do, in all seriousness, I still do recommend ice. The biggest thing is I try to tell people that just resting, icing, and compressing it is not going to be enough to really facilitate healing like we need to. So it's one of those where, like everything in medicine, it's about compromise, right? And this is what I constantly tell patients is, when you come to soft tissue injury, you need to use a little bit of our brain, right? Things that hurt, try to avoid, right? And your body is smart. It's gotten us through many centuries on this planet, right? So being able to listen to our body and make those adaptations. But then I will tell you that not a lot of people will tell you Google can be a great resource when you're talking about tissue. Now, you have to be careful about the resources on Google that you use. But I will tell you, let you in on a little secret. A lot of your doctors are using Google in the back room too, right? So it's one of those where it's a huge reputable source that UAB, our National Medical Society, the American Medical Society for Sports Medicine, the American Orthopedic Society, AAOS, has lots of great patient resources available for fracture care, for soft tissue injury, where you can really arm yourself with knowledge. And, when it's 3 a.m. in the morning and kid falls out of the bunk bed on vacation, it's one of those of, do I need to go to the ER? You can visit our UAB Sports and Exercise Medicine website. You can visit those reputable sources and really kind of walk through, do I need to go?
Awesome. Fantastic information. Well, you guys have been awesome, provided us with so much knowledge. We appreciate y'all taking some time to jump on with us tonight and share all your wisdom and guidance. And thank you for taking the time.
Absolutely. Thank you for the opportunity.
Absolutely.
Go Blazers.
Go Blazers. I like it. A quick reminder, a recording of tonight's webinar will be uploaded onto our website early next week. Attendees will receive an email once the replay link is ready. And before we go, here's a look at other upcoming webinars, including the final two in our Push to Play series for families of young athletes. On Tuesday, July 18th, come back for nutrition, fueling, and hydration. The fourth part of our series will take a look at what we should be encouraging our kids to consume. Then on Thursday, July 27th, join us for Performance Management, Your Deed to Success. During this webinar, we'll take a look at the topic and discover why it begins with clear expectations and enforced accountability. Before our kids return to school, be part of tips and tricks for curing the back-to-school blues on Thursday, August 3rd. That night, we will welcome a panel of educators who will share what we need to know as we head into the new school year. And on Wednesday, August 30th, we will host the final part of our series with mental health and young athletes, stress, eating disorders, and more. This session will take a look at the mental side of youth sports. You can register for all these and more at alumni.uab.edu/events. Finally, let us know how we're doing. What were your thoughts on tonight's webinar? What would you like to see in the future? The QR code on your screen takes you to a very brief survey. Take a moment and share your feedback. Once again, thank you for joining us for tonight's webinar. And as always, go Blazers.